All right, we're going to talk about diuretics. Make sure you review, you go over the diuretics overview physiology audio lecture. Okay, so overview of kidneys. The functions of the kidneys is to filter out waste. Does this via, it filters out creatinine and blood urea nitrogen. It conserves essential substances like sodium, water, glucose, and potassium. Metabolic effects, it can excrete or reabsorb electrolytes in water. It can excrete or reabsorb bicarb and hydrogen ions, which help maintain the acid-base balance. There's approximately 1 million nephrons in the kidneys where the diuretics exert their effect. Your glomerulus is where the filtering of the blood occurs, and that determines your glomerular filtration rate. And your renal tubules, that is where either it's determined whether stuff is going to be excreted out as urine or it's going to be reabsorbed back into the blood. So the mechanism of action of diuretics, basically, they accelerate the rate of urine formation, which will decrease the intravascular fluid volume, which will decrease blood pressure. They cause direct arteriolar dilation, which will decrease systemic vascular resistance. It is used for any condition where there's fluid volume overload. So that would be used, they're used for heart failure, they're used for edema. They're basically safe and low cost. They're the most commonly used drugs in the world, and prescribed drugs in the world. Classifications, these are different ones listed here, and we're going to talk about them more specific in the next few slides. The most potent is the loop diuretics, and then it goes less potent is the osmotic, then goes to thiazide-like diuretics, then thiazides, and then potassium-sparing diuretics are the least potent of the diuretics. The more sodium and water they inhibit from reabsorption, the greater the amount of diuresis, which means increased production of urine. Okay? So the stronger they are, the more urine they produce. So your carbonic anhydrase inhibitors, okay, their mechanism of action, they decrease the production of hydrogen ions and bicarb in the renal tubules, which causes osmotic diuresis of potassium and sodium and water and bicarb. The adverse effects are a result of the osmotic diuresis of potassium and sodium and bicarb, which means it can cause acidosis because it's keeping the hydrogen ions and excreting bicarb. It can cause hypokalemia because it's getting rid of potassium. Generalized weakness, numbness and tingling. The numbness and tingling can be in their hands, fingers, feet, toes, mouth, lips, tongue, or anus. Okay. Contraindications if they have hypokalemia or hyponatremia, because it's going to make it worse. Severe renal dysfunction, because we're altering the kidneys, okay? We're manipulating the kidneys. If they already have a problem with kidney function, we don't want them to be on it. Adrenal gland insufficiency, because adrenal glands if they don't produce enough cortisol and sometimes aldosterone, which will increase the potassium levels and decrease sodium levels and water. Okay, interactions. So your carbonic anhydrase inhibitors and digoxin can cause the dig toxicity. If you add them with corticosteroids, it can cause hypokalemia because the corticosteroids can cause hypokalemia anyway. Your carbonic anhydrase inhibitors can increase the effects of amphetamines, carbamazepine, yeah, okay. The next one, cyclosporin, phenytoin, and quinidine. Nursing considerations, we want to monitor electrolytes, especially our sodium and potassium, okay? With patient teaching, we want to report any changes in senses, like any numbness or tingling, because that would tell us that there might be a problem. Loop diuretics, okay? These are very potent diuretics, okay? They block the reabsorption of sodium and chloride. They prevent the reabsorption of water. Adverse effects, mostly they're going to decrease sodium and potassium levels and to a lesser degree calcium levels. So they cause dehydration, hyponatremia, hypochloremia. Again, this is all due to the mechanism of action. So we want to make sure that we're monitoring the electrolytes, monitoring the urinary output. It does put them at increased risk of thrombosis and embolism, so we want to be aware of that. Hypotension, we want to monitor their blood pressure. We want to tell them to avoid sudden changes in position because of the orthostatic hypotension. Ototoxicity, it's transient with furosemide, irreversible with others, which means so with furosemide it can come and go, but it can be permanent with other loop diuretics. So you want to instruct the patient to report any tinnitus, which is ringing in the ears, and also to avoid any other ototoxic drugs. The ototoxicity is mostly with prolonged administration of really high doses of furosemide. So hypokalemia, so we want to monitor potassium levels, we want to monitor cardiac status. Signs and symptoms of hypokalemia would be nausea, vomiting, fatigue, leg cramps, and weakness. So we may give them supplements if they're on loop diuretics to help prevent the hypokalemia. It can decrease levels of calcium, magnesium, and HDL. So we want to monitor these levels as well. Signs and symptoms of low magnesium are weakness, muscle twitching, and tremors. It can also increase levels of glucose, uric acid, and LDL levels. So we want to monitor levels. We want to watch for signs and symptoms of hyperglycemia. Contraindications, anuria, which is no urinary output, because that would mean that it's not getting any. Caution with patients who have cardiovascular disease, diabetes, dehydration, electrolyte depletion, or gout. So interactions are here. Basically, it's going to cause toxicities, things that decrease the... So with DIG toxicity, we're looking for ventricular dysrhythmias due to the hypokalemia. So we want to monitor DIG levels. We usually use potassium-sparing diuretics to reduce the risk of this instead of using loop diuretics with digoxin. With loop diuretics and NSAIDs, decrease the diuretic effect because NSAIDs decrease blood flow to the kidneys, which will reduce the diuretic effect because causes renal vasoconstriction. Loops plus antihypertensive drugs, they can potentially cause hypotension, so we want to make sure that we're monitoring their blood pressure. With loop diuretics and lithium toxicity, with lithium can potentially cause lithium toxicity due to the hyponatremia, so we want to monitor lithium levels. Nursing considerations, we want to make sure we have a baseline blood pressure and electrolytes, weight, edema status, I's and O's before we start. We want to administer it late in the day. Avoid administering it late in the day because it will cause nocturia, and that means they're up all night peeing. So generally, we don't want to give it after 2 o'clock p.m. in the afternoon, okay? So they should get it first thing in the morning. If they have to get an IV infusion, we want to do it very slow to help prevent hypotension and hypovolemia. We want to notify the provider if the potassium drops below 3.5. Patient teaching, we want to monitor blood pressure and weight, so they should keep a journal. We want to avoid sudden changes in position due to the drop in blood pressure from the decreased intravascular volume. We want to report any signs and symptoms of hypokalemia, hypomagnesemia, hypocalcemia, which are listed there, and then if they report any tinnitus or hearing loss. They should eat foods that are high in potassium to help prevent hypokalemia. So osmotic diuretics. Mannitol is a sugar alcohol that's found in fruits and vegetables, just FYI. Mechanism of action, it works along the entire nephron. It pulls fluid into the renal tubules from the surrounding tissues. So it pulls fluid from the brain, the eyes, to decrease swelling. Remember, water follows sugar. So if you increase the sugar concentration, it's going to pull water to that area, okay? So this helps to decrease edema in the surrounding tissue and increase urine production because you're increasing intravascular fluid volume. Inhibits the reabsorption of water and solutes, so it increases urinary output. It's not for peripheral edema. It only sucks in fluid from the surrounding tissues. So indications, it's used for preventing kidney damage during acute renal failure. It's only used during an oligoric phase, which means a urinary output less than 30 mLs per hour, because it will actually draw water into the renal tubules, which will force urine production, which keeps the kidneys from shutting down. So it keeps perfusion to the kidneys. It also reduces intracranial pressure and cerebral edema with head traumas, which means it takes fluid from the intracellular space to the extracellular space, thus decreasing cerebral edema because it comes out of the cell. Can reduce intraocular pressure, which means it draws intraocular fluid, which is fluid from behind the lens, into the bloodstream, which is taking the pressure off the eyeball. So it can help with that. Okay, so adverse effects are due to the increase in intravascular fluid volume from all that fluid going from inside the cell to outside the cell. Heart failure or pulmonary edema from the influx of extra fluid. If signs and symptoms of heart failure develop, we have to stop the medication and notify the prescriber. Rebound, increased intracranial pressure. Signs and symptoms of increased intracranial pressure is a change in level of consciousness or pupils. They may have a headache, nausea, vomiting, stuff like that. Fluid and electrolyte imbalances or metabolic acidosis. Signs and symptoms of that would be drowsiness or restlessness. So contraindications, anuria or renal failure, severe pulmonary edema, they would use loops instead because mannitol does not help pulmonary edema. Active intracranial bleeding, because increased extracellular fluid will increase the fluid loss from the intracellular bleeding. Severe dehydration, because it will dehydrate the reserves in the intracellular fluid. Use caution with heart failure, renal insufficiency, and electrolyte imbalances. Interactions, you see them here that mannitol will decrease lithium levels, so we want to monitor lithium levels. With cardiac glycosides, it can increase the risk of hypokalemia, so we need to monitor EKG and potassium levels. So the forms of mannitol, it comes in different concentrations of sugar. So your considerations, we want a baseline and daily blood pressure, weight, electrolytes, edema status, and I's and O's. Again, if the potassium drops below 3.5, we want to monitor an EKG, and we want to notify the prescriber. Double check calculations with another nurse. It's a continuous infusion. Now, it will crystallize when it's exposed to low temperatures, especially when it is 15% or greater concentration. So we need to store it in a warmer so that it doesn't crystallize. Okay, this warms it up to 37 degrees Celsius, helps to dissolve any crystals if any had started to form. It will actually crystallize at pretty low temps. So if we warm it up to 37 degrees, which is 98.6, it will dissolve any crystals. We want to use a filter needle to draw it up so that if there are any crystals, it will not go inside the person. Always administer through a filter because it will take out any crystals that are formed. And then visually inspect it prior to administering it. You should look for any precipitants floating around in there. Monitor for signs and symptoms of increased intracranial pressure. You want to monitor for metabolic acidosis, which again is that drowsiness and restlessness. Patient teaching they should get up slowly because there's a high risk for postural hypotension. If they are dizzy or faint, they need to lie down. They need to report any significant weight loss, lightheadedness, dizziness, GI distress, or just general weakness, because this could indicate hypokalemia or hypovolemia. When we're evaluating effectiveness, we want normal kidney function, so we want a urinary output of at least 30 mLs per hour, a serum creatinine that's within normal limits, and a BUN that is within normal limits. All of those would give us evidence that there's adequate kidney function and perfusion. We want decreased intracranial pressure and decreased intraocular pressure if it's for the eyes. So potassium-sparing diuretics. So remember that aldosterone tells the kidneys to keep water, keep sodium, and excrete potassium. Okay? So these are called aldosterone inhibiting diuretics because they inhibit aldosterone. Okay? It's relatively weak compared to the thiazide and the loop diuretics, which we already talked about. So it blocks the aldosterone receptors. So water and sodium is excreted then, and potassium is retained. So they are at increased risk for hyperkalemia. So your adverse effects are hyperkalemia. So we need to monitor the levels and signs and symptoms of hyperkalemia, which are weakness, fatigue, dyspnea, and dysrhythmia. We need to stop the medication or give a non-potassium sparing diuretic or glucose and insulin if they have hyperkalemia. If you remember, insulin helps the potassium to go inside the cell temporarily, so we can use that if we have incidences of hyperkalemia. Endocrine effects due to the suppression of aldosterone. So remember, aldosterone is a mineralocorticoid, which is a corticosteroid hormone. So in the male, it's going to cause a deepened voice and impotence. Females, it's going to cause an irregular menses. It can cause drowsiness and metabolic acidosis as well. So uses, it decreases the intravascular fluid volume, which will decrease the systemic vascular resistance, thus decreasing blood pressure. So it's used for hypertension and sometimes used for heart failure. It can be used for hyperaldosteronism, which is when patients secrete too much aldosterone, because it will suppress the overstimulation of aldosterone. It can prevent hypokalemia from other diuretics, so it could be paired with a non-potassium sparing diuretic like a loop or a thiazide. Contraindications, hyperkalemia, or if they're taking potassium supplements, because that would put them already at risk for increased potassium levels. Severe kidney failure or anuria. We're going to use caution in kidney or liver disease, electrolyte imbalances, or metabolic acidosis. Interactions, really they just increase the risk of hyperkalemia. All of these medicines increase the risk of hyperkalemia. So ACE inhibitors, ARBs, direct renin inhibitors, concurrent use of potassium supplements, salt substitutes, because we talked about salt substitutes are potassium, and then other potassium-sparing diuretics. Nursing considerations, we want to make sure that we have a baseline and a continuously monitoring the weight, blood pressure, I's and O's, and potassium levels. Periodic ECGs to check on rhythms. Patient teaching, they need to avoid salt substitutes because they're high in potassium. They are basically potassium chloride. They need to reduce the intake of potassium-rich foods. This would be like oranges and bananas and dates. Want to monitor their own blood pressure daily in a journal. Triamterene can turn the urine a bluish color. So just FYI for that one. Report any cramps, diarrhea, thirst, altered menstruation, or a deepened voice. Avoid activities that require alertness until the effects of the medication are known. Because it decreases the intravascular fluid volume, decreases the blood pressure, it's going to make you a little tired at first. Effectiveness, we should have normal potassium levels. We should have a decreased blood pressure and a decrease in the edema. So thiazides and thiazide-like diuretics, they're chemical derivatives of sulfonamide antibiotics. So if they have a sulfonamide antibiotic allergy, we want to use caution with using these medications as well because they're very similar. Thiazides, hydrochlorothiazide, is the most commonly used one, and it's very inexpensive. You have your thiazide-like diuretics. Metolazone is effective in patients with renal dysfunction. This is something that makes it special. Mechanism of action, it inhibits the reabsorption with sodium, potassium, and chloride in the distal convoluted tubule, which means it promotes reabsorption of calcium. This prevents reabsorption of water, so the water goes out in urine. It also has direct relaxation of your arterioles, which will decrease systemic vascular resistance. Adverse effects is dehydration, so we want to monitor for signs and symptoms. Decreased potassium, sodium, magnesium, and chloride, so we want to monitor those levels. Monitor for signs and symptoms of hypokalemia and hypomagnesemia. Increased uric acid, glucose, and LDL levels. So we need to monitor, make sure we're monitoring those levels, especially our diabetic patients. We need to closely monitor the glucose levels. So uses, hypertension, and edema. Diabetes insipidus. Diabetes insipidus is when the body makes large amounts of undiluted urine. So it will help reduce the urine production. Postmenopausal osteoporosis, because it helps promote reabsorption of calcium. Contraindications, pregnancy, it will decrease the maternal and placental blood volume, so we don't want to use it. Renal impairment, except for metolazone. Metolazone, actually you can use with a GFR as low as 10, so it's pretty special with that it can be used with renal failure. You want to use caution with cardiac disease, diabetes, hypokalemia, hyperlipidemia, hypomagnesemia, and gout. Thiazides will just make all of these worse. Interactions are same as your loop diuretics. Nursing considerations, baseline and monitor orthostatic blood pressure, weights, electrolytes, edema status, the location and extent of the edema. Notify the prescriber if the potassium drops below 3.5 and monitor ECGs. So patient teaching, they should take it first thing in the morning, again to prevent nocturia, which means that they're constantly getting up to pee in the middle of the night. They need to consume foods high in potassium. They need to maintain adequate fluid intake. If they have a GI upset, they can take it with medications. They need to do daily weights and a blood pressure with same clothes, same time, and write it in a journal. Change position slowly. This will minimize postural hypotension. They need to lay down if they're faint or dizzy. They need to report any significant weight loss, lightheadedness, dizziness, GI distress, general weakness, because these are signs and symptoms of hypokalemia and hypovolemia. They need to observe for any signs and symptoms of hypomagnesemia, which is, again, the weakness, muscle twitching, and tremors. Evaluation of effectiveness, they should have a decreased blood pressure, a decrease in their edema. They should have increased urinary output. If they have diabetes insipidus, they should have a increased urinary output. If they have diabetes insipidus, they should have a decrease in urinary output. And then preservation of bone integrity in patients with postmenopausal women that are at risk for osteoporosis. So in general, with diuretics, what are you going to assess? Baseline breath sounds, heart sounds, neuromuscular status, because it can indicate electrolyte imbalances. Skin, mucous membranes, cap refill, that's going to tell us our perfusion and edema status. Vital signs, daily weights, eyes and nose, that will let us know hydration and fluid vascular volume status. Labs, we want to check renal and hepatic functions. So that would be our creatinine, our AST, ALT, BUN. Electrolytes, to check for any electrolyte imbalances. Other meds they are on, potential for toxicity like digoxin, lithium, NSAIDs, and other antihypertensive medications. We need to check for those. Past medical history, especially of renal or hepatic dysfunction, that would mean that the medication is going to stay in their system longer, or it's going to further damage any renal dysfunction. If they have a sulfonamide antibiotic allergy, remember there's a potential cross reaction with thiazide and thiazide-like diuretics. So we probably would not want to use those diuretics if they have a sulfonamide antibiotic allergy. Now here is just an overview of your signs and symptoms of electrolyte imbalances. So it's very important that you know these. So make sure that you look over them.